And okay, so we have started the recording. Thank you all for joining us this evening. It's good to hear from you. Oh shoot, is this our first class since the storm?
We had class last week.
Was that after the storm?
Well, it depends on your before and after
Irma.
period.
Is this our first class
First,
since Irma?
yeah. Well, Irma was past us last Tuesday.
Oh, was it? Oh.
Yeah, it was. It was clear that it wasn't going to do anything to us, but it already beat up everybody else.
Well, I hope everyone continues to get back to as normal as can be. And we'll just have to see what Maria's going to do, since that looks to be a problem as well. But tonight, I'll try to keep the main thing. This is lecture 2 out of 2 in our second module on initial assessment. We're going to pick up where we were last go round, which was, I believe we were finishing up family history.
Yeah, you had talked about genograms.
We got the genograms? Okay.
Yeah, and I think one of the things about genograms that's really helpful is that when you've got a person with kind of confusing family history, to draw it out on paper is an excellent tool to, number one, demonstrate the fact that you listen carefully, and also because you'd be able to understand family dynamics in a different way than just having an oral presentation. So a genogram is a great tool, so you can say, let me see if I got this correctly. Does this look like the family that you just described to me? Did I miss anybody? Because sometimes people's memories don't necessarily cover all the people that were significant in their life. And there may have been somebody who was very significant to them that isn't in their direct family tree. It isn't necessarily helpful for genetic information in terms of what disease processes they might have inherited from family, but it's really helpful from a family dynamic system if someone outside of the family was a significant force for them. And you'll only pick that up a lot of times through using a genogram.
It just sort of puts the relationships, and then you can kind of map on there, well, my grandma had nerve problems, or my uncle had to go to the state hospital a bunch when he was younger, those kinds of things. Because with the family, and really it's the family psychiatric history, is like Dr. Fogger's saying, you're trying to do, they call it the poor man's pharmacogenomics, is to figure out the genetic loading. Because you may be working with someone, you can't quite put your finger on it. It's maybe an atypical, I don't mean atypical because that's a specific thing. It's some symptoms of depression, but there's a lot of, maybe there's some agitation, activation there, some impulsivity, which is not a symptom of depression. You might be thinking, I don't know if I should treat this with antidepressant or a mood stabilizer, and then you ask about grandma, grandpa, mom, dad, and a mom and her brother were on lithium in midlife. So that will tell you, this is more than likely a bipolar disorder as opposed to a unipolar kind of depression. So, and also if you can do genetics testing with people, we strongly encourage you to do so, at least to recommend it as an option to the patient, because it's really helpful for treatment planning purposes. But we talked about this last time.
Yeah, I think that's where we got into, depending on what the clinical site was, is either they'll be able to use it or not.
Right. And insurance and those kinds of things. So social history is the patient's kind of their history, their story in the world. Oldest child, you can start, and I usually say this part, and when I'm doing intakes with somebody, I'll say, okay, now the next few questions I'm going to be asking back in the way back. We're going way back to the beginning, meaning your birth. And you have siblings. Were you raised with your siblings? Biological, adoptive? If you want to get super detailed. The main thing you're looking for is, did this person come from an intact family? Were they pretty settled? Were there step parents? Were there multiple boyfriends and girlfriends? Did they move around a lot? Were they foster children as young people? Were they adopted at some point? Just how stable, how consistent, based on that report, do you think needs were met? Were they exposed to a lot of chaos as young people? Were they exposed to parents who were fairly volatile? Because kids learn coping mechanisms and emotion regulation from watching adults exhibit those characteristics. So if you have a lot of fighting and arguing and revolving door, was there substance use in the home, those kinds of things, that's what you want to know, because it may inform your assessment of personality and coping behaviors that can make a mental illness present better or worse. So you're also going to ask, oh, I'm sorry, did somebody say something?
Yeah, it was me. Can you hear me? I was just going to interject that this would be a good place that if the person had already completed some measurement tools to look to see what their ACE score was as a way of kind of understanding what their social history looks like. The ACE score determines the amount of trauma that they are exposed to as children, and it's not a bad tool to look at, whether you use it in practice or not. If you're dealing with people who have a high potential for trauma, it's very helpful to begin the dialogue.
Really good point. Yeah, that's the adverse childhood experience or adverse childhood event. Is the E for experience? I just call it ACE.
I don't recall because I'm mostly focusing on the ACE piece of it. Experience or event is kind of a moot.
True. Good point. Yeah. Inconsequential. So if you want to be a psychologist, then you can really go to town on, oh, you're the middle of 5 or you're the youngest of 2. But that is probably not tremendously relevant to their current symptom picture as far as medications are going to be concerned. But it's still interesting and important to find out because you're trying to sort of get to know these people and where they come from. When you're going to the way back, because this includes, even for adults, did you level of education? Did you finish high school? You get any college? Did you drop out at 15 because you had to go to work and get a GED? So what was their school, and especially if you're working with kids and you're trying to get a social history about child and adolescent development, because that's tremendously important. And you would get additional history from a family member, a parent, of course. But how was their experience in school? Did they like school? Roughly what kind of grades did they get? Did they participate in extracurriculars? Were they teased and bullied? Because that's a big thing. Did they have a pretty tight friend group? Did they get into trouble? Did they skip school? Did they have a lot of in-school suspensions? You can probably guess that a social history, what kind of diagnoses or disorders do you think a social history can give you insight into? Social history specifically. You're on the right track. Exactly. Antisocial disorders, interpersonal, right, personality disorders, exactly. Social history is this person's track record functioning in a society, and the class of disorders that is a problem of interacting with society are the personality disorders. So you're looking for trends of relationship conflict, legal trouble, difficulty fulfilling kind of societal obligations that we all sort of accept, like working, like obeying the law, like not getting arrested a whole bunch of times, not getting involved in drugs and gangs and illegal activities and wanting to be a functional member of society. So that's, and you can see, well, in school, were there behavioral problems at school? Is there just this really inconsistent work history? They can't keep a job, or they argue with bosses. Those themes will start coming through when you're talking with somebody about this. Oh, my boss was a jerk, so I quit. Or, I just really don't care to work. I'll go live with somebody else. Or if they were a really high functioning kind of person. Exactly. Is this somebody who had a job and had a family and had hobbies and interests, and then something traumatic occurred, or they got some illness, or just one day there was a significant change in functioning? This indicates functioning. With every disorder in the DSM, it's not a disorder unless it causes significant impairment in functioning. And this is sort of how we gauge achievement of societal milestones. Work history, we mentioned that. Military service. Important to ask, have you ever served? And those of you who are at the VA are probably getting to be pros at assessing for military history, but you want to know which branch did they serve? I think we touched on this at the on-site. What did they do specifically?
I was going to say, it doesn't hurt to review it.
Right. What was their job? What were they assigned to? Their MOS. But in addition, were they ever responsible for other things outside of that? Because additional responsibilities may have been out of necessity. And even if you were a cook, there may have been times when you had to go out and do things unrelated to cooking that could have potentially exposed them to death or violence or those kinds of things. Did they enlist? Were they an officer? What rank did they achieve at the end of their service if they have, retired? How long did they serve? And also deployments. If so, where to and when? Did they see any direct combat? And we should ask in the medical history about history of injuries to the head, but especially with vets who've seen combat, the risk of an injury to the head is greater. Or obviously, were they a jump master, so they were jumping out of airplanes all the time and falling and banging onto the ground? You want to ask about history of head injuries, which could be a car accident, any kind of accident, training accident, where you hit your head hard enough and you felt kind of dizzy, you were a little disoriented, you felt fuzzy, had some memory problems, trouble remembering details, did you actually lose consciousness? Those are all brain injuries. Even hitting your head and being kind of confused is sufficient for a brain injury. And yes, someone asked about discharge status, right? Honorable, general, dishonorable, rank, duration. Good question. Married, is the person married? They have kids. What do they do in their spare time when they're not working or doing whatever else? It's okay to sort of get to know these folks as folks with interests and aspirations and unique qualities, and that can also help down the road with conversation, is to ask them about the cars that they're working on in the garage or those kinds of things. Yes, sexual preference, Deborah. Does the person identify as straight or gay or bisexual? Are they, I think sexual activity is going to be in our medical history. I don't think I'm looking ahead on our slides, and I don't think we actually say that, but yeah, you would ask about that. especially if it's relevant or really thorough. And if you ever read over probably a psychological assessment from anybody, they would ask about sexual preference current. And, say a lot of times folks in high school will then experiment with or have sexual interest in people of the same sex or the opposite sex or whatever. I don't know how relevant that would be or how important that would be to get, but sure, that's where that would go. Are they currently sexually active? Do they use any sort of contraception? Are they in a monogamous relationship? But as far as sexual history, oh, can y'all hear me? Cecilia is saying that she's having an audio problem. Okay. We'll just type, hey, you, if there's a problem with the audio. And that will go in and out for y'all. Okay, thank you, Carmen. If audio drops for you and it doesn't come back quick, just log out and come back in. That happens all the time to folks. So just log out and come back in. It'll be fine. Where were we? Oh, yeah. So talking about sexual history. But that's a good point, Dr. Fogger, about multiple partners. And, something else to think about is if this is your first visit with a patient, just use some reasonable judgment as to how important is this information to the clinical picture today. And since this person doesn't know me very well, do I really need to get that information today? Maybe, maybe not. But thank you for that comment, Deborah. That's a good observation that had not been included right here. See, sexual orientation can be a source of family or social conflict. Yeah, Tracy, that's a good point. Working with adolescents, folks who are, just getting into the peak of hormonal raging, asking about risky behaviors, attitudes about sexuality. Again, that may be a lot more difficult if it's an initial visit with a 14-year-old. But there are ways to ask about risky behaviors and sex is a risky behavior when you're an adolescent because judgment is non-existent for the most part. But ways to ask it in a not threatening, kind of normal symptom expectation kind of way. And Carlett does a good job in offering some recommendations for that Carlett's really helpful to say, I know nobody likes to talk about this, but I know a lot of kids in high school, a lot of kids your age are kind of starting to get, getting interested in dating, and some folks are even starting to have sex with girlfriends and boyfriends, and not a lot of people are using protection. What do you think about that? What are your friends doing? What does your friend group think about that? And it's a way to get the patient's opinion or thoughts without actually asking them, what do your friends think about that? Are your friends kind of, like the folks you hang out with, what's y'all attitude on that? Is that something you've kind of started to get involved with? Or so there's ways to ease into really difficult, uncomfortable conversations with strangers, which we are to these people. Substance use history. Wah, wah, wah. Definitely a question to ask when you're working with adolescents, for sure. Along the same lines of what do the kids at your school do? The folks you hang out with, have they gotten into smoking? They smoke pot sometimes, or they like to drink? How much do they drink? Symptom expectation. How much do y'all normally drink on the weekends? When y'all have parties and get-togethers, who usually brings the beer? Who gets it? That kind of stuff. And they might say, oh, we don't do that, which is fine. But if you say, y'all don't drink, do y'all? They're going to say, no, we don't. So be conscious of if you're Oh, so Dr. Fogger, who is the substance use treatment expert among us, says don't say, you don't drink, do you? Y'all don't do that, do y'all? We want to be very inviting, set a really wide net so that the patient has tons of room. Karen says, heck no. Leading the witness. I want you to tell me no so I don't have to deal with this, so I don't have to decide if I need to talk to your parents that you're drinking at parties and driving drunk and all those kinds of things. So substance use history, everything from what's your current caffeine intake? Because again, we're talking about intakes here, and intakes is a big job because you're trying to figure out the current symptom picture, current symptom acuity, but also their whole history. So, do you smoke? How many packs a day? Like, are you a 1.5, 2 pack a day smoker? You can exaggerate and inflate it so that they'll be more likely to be honest because it's probably less than what you're going to say. Or have you ever smoked? Prescription drugs. The person's prescribed Xanax. How long does a prescription last you? Do you find yourself having to do the 28-day refill or asking for earlier? Do you ever take other people's prescription medicines, pain medicines, benzos, those kinds of things, which is probably huge, especially in adolescence, because parents don't keep an eye on their medications like they really should. And that's scary stuff. Are they taking their own prescription inappropriately, other people's prescriptions, which by definition is inappropriate? Marijuana. Ever tried it? Do you smoke, or you ever experiment with that when you were younger? Ever tried it? How'd you like it? Real non-judgmental, real inviting, just to make it possible for them to give you accurate information, hopefully. Pain meds, spice. Bath salts were popular for a while. And just asking, do you ever use anything to change your mood? Yeah, cough medicine. Purple drink. Why not? Right, to say, so do you ever do that kind of stuff? And what do you like about it? Because people do stuff that serves a purpose. Alcohol is a highly addictive substance for some people, not for all people. And it is advertised on TV and billboards, and it's really cheap. And it's everywhere, which makes alcohol one of the more likely to be abused substances. For women, what are the limits? Remind us about the limits for this stuff. How many drinks per occasion? All right, Karen is gonna just steal all of the thunder. I see. Oh, Karen, by the way, if you're willing to mute your mic, I didn't mean to mute your mic for you, but we were having some noise. So if you'll mute it, it's all you. I unmuted you.
Okay,
Yeah,
thank you.
women can have up to 3 in a sitting, up to 7 in a week. And what is it for men? These are the 4 and 14. Yeah. And that's how many ounces of wine, beer, and liquor? What you think?
5 ounces of wine.
Yep. 16-ounce beers? How much beer? Tall boys? 12? Yep. And liquor will be 1.5. So just, and this is an interesting conversation every time I have it with patients, because I'll ask them, how's their alcohol use? As far as alcohol, how's that going for you? how much a week you think you have. Oh, and they'll say, I have 3 or 4 tall boys a day, and I'll say, how many ounces? And then we get into a conversation about how many ounces is in that, and maybe it's a 20-ounce beer, and we calculate that out to be, okay, that's 80 ounces, and I say the folks who study alcohol and the point at which it can be problematic for men will say, 14 a week, or really no more than 4 in a sitting, and you're about 3 beers on top of that, you're almost to your weekly limit in a day. And just telling that, just having that conversation with people and calculating it out, getting them to more deliberately analyze the data. You just look at the data. How much am I actually drinking? What does that calculate to? Is enough for them to say, wow, I didn't realize it. So when you're taking a motivational interviewing approach and the Prochaska DiClemente stage of change, the first step is information gathering. Like, let's just look and see what's going on here. So having folks do a food journal, having folks pay attention to how much money they spend on alcohol, how much money they spend on cigarettes, how many times a day they have to leave the office to go smoke. Just pay attention and gather some data. When it is a problematic behavior, well, they will inevitably arrive at a conclusion that, oh, wow, this is a problem. This is a lot of money. This is a lot of time. This is slowing down productivity, whatever it is. So folks who are pre-contemplative, information gathering is the place to start, and doing a expert kind of quantity analysis with them is a great way to do that. And y'all are very smart, so y'all got all that right. You just filled in the numbers right there. Standard drinks, blah, blah, blah. The idea being that people who are drinking consistently more than these amounts are putting themselves at risk for a substance-related negative consequence, be it physical, metabolic. Their sleep is more likely to be disrupted. Blood sugar, blood pressure, triglycerides. Cancer. Cancer of the GI tract, ulcers, and additionally, kind of going back to that pre-contemplation, information gathering, looking over people's lab work. Worked with a guy recently who drinks he was drinking 1.5 liter bottles every evening when he got home from work, and he de-escalated, you could say, to about a 12-pack of beer and of wine, 1.5 liter bottle, the big, like the double wine bottles. And so we looked over his labs, and LFTs were elevated a little bit, but his triglycerides were about 400. And I said, man, your body you are not processing all of this sugar at all. And this is going to set you up for a stroke, man. This isn't good. So going over labs, getting that, and then how much money he was spending and how much time he was spending. Setting them up to make the decision for themselves, because we can't want it and we can't push. The more you push, the more they push back. So in the substance use history, have they ever got a DUI or arrested for public intoxication, or did people ever tell them they drink too much? You can kind of go into a cage screening if the person's maybe drinking above risky limits and you want to see if there's consequences of it. Do people tell you need to cut back? Does that drive you nuts? Lots of DUIs, that's an issue. Oh, I don't have a license anymore. That's significant impairment due to the substance use, so that's going to be a substance use disorder for sure. And other drugs, like I believe either Deborah or Karen wanted to be sure. If you smoke, what do you smoke? Yes, that matters a lot. And also how long you've been doing this. For someone who's a heavy user, have you always used this much, or did you start off less frequently? People who don't drink now, was there ever a time when you drank more than you do now? Like, say the person, I have a couple beers a couple times a week. Well, was there ever a time when you drank more than that? Because with an intake especially, you're trying to see what's current, but what's the history to establish patterns and courses. So has there ever been a time where you drank more than this, or has there ever been a time when you smoked more than a half a pack a day? And also, be real, you want to quantify as many things as you can. So to be specific about, well, how much do you drink and how often? How many joints a day? How many bowls a day do you smoke? How many days a week do you smoke? How long you've been doing it at that level? Have you ever tried to cut back? If so, did you find it hard to, especially with alcohol? Would you get real anxious? Would you ever get shaky or sweaty? Have you ever been treated or sought treatment for this? Been in a formal substance treatment setting? All good questions and observations that y'all have. I don't think I have any other thoughts on that. Medical history, yeah, it's relevant. Cardiac history, did they have an MI last year and their depression worsened? Things like diabetes and high blood pressure, hyperlipidemia, those are risks for vascular dementia. Finding folks here consider a 24-ounce beer to be one beer. It is technically a one beer. Technically, that is true. But y'all know, like, oh, I have 3 or 4. Y'all, you have tall boys, you got the 12 ounces, or do you have those little 7-ounce, tiny little things? The ounces matter, and that's how you can convert it to the standard drinks. Right, exactly. Medical history, do they have COPD and pernicious anemia and hypothyroidism? Things that can look like anxiety and depression. You want to ask. You want to ask about allergies to any medicines. What surgeries have you had in your life? Because true, we are psychiatric nurse practitioners. That is our specialty focus. But we are also advanced practice nurses, which means we have to screen for just basic medical for everybody. Partially because it may implicate treatment and diagnostic decisions, but also because we might be the only medical person that these people see, especially in real rural areas. Depression post-heart surgery. Yes. Yes. Very true. Heart surgery, heart attacks. Norepinephrine is kind of what makes your heart go. And norepinephrine is intimately involved in attention and energy and interest. So when your system is trying to minimize stress to a really vital organ, then you may go into protect mode and have some depressive symptoms present as well. Stroke, a well protocol, psychiatrist after stroke. Yeah, current health problems, previous health problems, real bad fevers, anoxic brain injuries. Oh, here's the brain injury issue that's coming up. Due to activity intolerance, can't do what they used to do. Right. So then you have situational external factors contributing to, well, this really sucks. Stamina's down. Oxygenation's probably not as fantastic as it should be. And anytime the body is under stress, you're going to conserve. and go into shell shock mode. Medications and treatments. And this is an issue in, right, Brenda's making a comment about just the role shift that happens after a heart surgery, heart attack. You can extend that to car accidents, to injuries, to you broke a leg and you're in traction for a while. You just need help. That the psychological impact of that is further complicates it, you could say. For your intake notes, kind of going forward, and your follow-up notes, as far as medications and treatments, what we really are looking for here is the patient prescribed meds or treatments that can mimic or exacerbate psychiatric symptoms. If a person has COPD and they're supposed to be on O2 and they're not, well, non-compliance to home O2, you're going to have to consider that in their anxiety and in their depression, in their anergia, in their poor concentration. If somebody they have sleep apnea and they don't want to use CPAP, well, then they're going to have headaches and a lot of pain and no energy and irritability. So, are they prescribed and are they adherent to treatments that have psychiatric implications? Not necessarily eye drops or Lipitor or things that really don't. But some blood pressure medicines, sure. Thyroid, B12, those kinds of things. You want the name of their primary care physician. You want the results of their last physical. You want to know lab work. And if you don't have it, then you order it. That's what you do. Because you don't want to treat depression that is actually anemia. And you don't want to treat anxiety or, some kind of delusional situation that's actually hyperthyroidism. You need to know this. Medical review of systems, and y'all know that. Headache, blurred vision, dizziness, runny nose, cough, cold, those kinds of things. Mental status. Everything up to now has been what the patient has told you. And if you have any questions, just holler out. We're kind of winding up on this bad boy here. The mental status is different because the mental status is things that you observe. You're not reliant on the patient's report to get any of this information. And the mental status can start from when you're calling the patient in the lobby to come back. Carlett gives great examples of wording for these, an amazing list of descriptors, which is really cool. But appearance, that's going to indicate self-care, organization, social appropriateness. Are they clean? Does the clothes fit? Are they disheveled? Their behavior, their interaction with you. Are they generally cooperative? Are they really guarded? Are they agitated? Are they restless and fidgety? Mood is what the patient says it is, but affect is what their mood looks like. And is it consistent with their report? Is the range of affect, is there a range during the interview? Do the facial expressions match the content of the speech, and does it fluctuate as the interview goes on? Do they exhibit, a thinking face, or happy when they talk about this, or kind of grimacing when they talk about harder things? Or is it more like a mask? I think was a term that in clinic the other day. There was a patient with constricted affect, not flat, because flat you got nothing. Constricted, there is some range, but it's kind of like You can hear the radio. The radio's on, but you can't really. It's really low volume, as opposed to the radio is off, would be flat. Low volume would be more like constricted. Speech. If you've worked with someone who is manic, then you know what loud, fast speech sounds like, what pressured speech sounds like, that they're talking so fast that you can't even interrupt them. Someone who's really depressed, or someone with negative symptoms of schizophrenia, their speech may be monotonic, delayed, low in volume, slow in rate, those kinds of things. And by specifying those observable factors lets you know that over the course of treatment, are those things improving? Is it more regular rate and rhythm, appropriate volume and tone? So by documenting these bits of data down the road, you can track it. Thought content. What do you mean? Oh, all caps. Right. What do you mean by pressured? I'm not pressured. You are pressured and in denial, my friend. Right, and these are folks who, you may interview people at some point who are so acutely ill that there is really not much point to interview them for content. Just by mental status, by observation, it is clear that they are agitated enough or manic, energized, cranked up enough that until you bring that down to more within normal limits, there's really not, there's no reliability to the information that they're giving you. So sometimes the only thing you need to see is the mental status exam is sufficient to arrive at a diagnosis and say, oh, this is an acute situation and we gotta take care of this person. Thought content. The person's speech may indicate delusions of persecution. People are after me. It's not necessarily that they're telling you, I am having a delusion of persecution. I am having a religious delusion or a delusion of grandiosity. No, they're not going to do that. But they'll talk about this conspiracy against them, and people are out to get them, and people are poisoning my food, and I'll answer that question in just a second, Cecilia. You can tell from the conversation if they're having fixed false beliefs, which is a delusion. Or they may tell you, yeah, I hear voices talking to me. And it's one people or it's two people. One person or two people. Or they may kind of pause and it looks like they're listening to something. And they may be responding to internal stimuli. So that is your assessment. It is not what they're telling you. You are observing them during the interview, and that makes it objective. Breaking in my apartment, leaving fingerprints on the wall, or there are muddy footprints on my back fence. I know people are breaking in and looking in my windows. I know it. There is no sure. There may be kids in the neighborhood who jump my fence, but that's not it. No. It's not those kids who I've seen do it a million times. It's somebody else who got fixed false belief. Don't argue with it. You can't argue with it. Rumination is a description of speech. Tangential definitely relates to thought process, because you can have tangential speech, but you can have tangential thinking with regular rate and rhythm. That it's not a getting the words out issue. It's the script that's in the brain issue. Now, rumination, which is probably the opposite of tangential, because ruminative or perseverative, they'll call it speech, but it's really, the person would be having those same thoughts even if they weren't saying anything. So it's really perseverative thinking that if the person will tell you about it would be perseverative speech. So that's not that distinction I don't believe is real consequential, but especially for someone who is having psychosis or someone who has OCD, they may have that perseverative thinking. Tangential is definitely a thinking issue. But tangential thinking is not organized. Ideally, thoughts are organized. They are logical. Okay, they're based in reason and reality. They're linear. They go from A to B to C, and they stay on track, trying to communicate a thought that is relevant to the right now. So linear, logical, goal-directed, as opposed to I took my car to the shop and 3 people on the way there were walking by the road. And, I just think that the city needs to do more about sidewalks because, kids can't play in playgrounds like that. There's just way too many people out there with those hurricanes. And, okay, that is not linear or logical or goal-directed. That would be probably my associations were a bit loose. Cecilia, don't stress too much about the distinctions between the two. They're really trying to describe the same thing. And mainly, someone who either gets stuck on a point and can't get off of it, like it can't quite reach escape velocity and get off that topic, that's not linear, logical, and goal-directed. And someone who is lost in space and will never come back to this planet, that's not organized either. And it's not necessarily what the person's saying, it's how they're doing it. Cognitive examination, alert and oriented times 4, do they know where they are and why they're here? Is attention sufficient for the interview? Can they remember memory? Can they remember house, ball, car? Can they repeat it to you right now and then tell it to you again in about 5 minutes? Do they know who the president is? The MOCA, the Montreal Cognitive Assessment Instrument, can assess attention and short-term memory and working memory and the ability to follow a multi-step sequence. The slums is another good example. It has a clock face drawing exercise where you have to draw me a clock and put the hour markers and the time at 10 minutes to 11. That is surprisingly hard to do. 10 minutes to 11. A really quick kind of math instructions to do a really quick math problem, because it requires people to keep multiple bits of information in mind and manipulate it, which is a pretty advanced function that people who are really depressed, they may be delayed in that. Folks who have dementia may be delayed in that or unable to do it. They'll say, well, what was the instructions again? Well, or the actual calculation is just inaccurate, which speaks to inability to follow more complex commands. Serial 7, start at 100, subtract by 7, and just go to town. Oops, come back. No, second to last slide, and then any questions that y'all have. Just things to kind of overarching is you only have an hour to get a lot of information. You want to get enough information to confidently arrive at a diagnosis. And the appropriateness of your treatment is only as good as the diagnosis that you come to. So if you only have an hour, you got 10 minutes left and you're still halfway through your HPI. Not so good. So keep an eye on the time. have a template, ideally. Have some sort of template, and then you can kind of jot down notes and also see, ooh, okay, I'm halfway done. I'm on pace, or I need to speed it up, or I can slow it down. As you do this more, you will start becoming more aware of some process issues like transference and countertransference. Patients that, or situations that get you worked up a bit, make you frustrated, make you calm, make you sad. Patients will, like everybody on the planet, have some healthy coping mechanisms and some unhealthy coping mechanisms, like excessive help-seeking behavior, or trying to guilt trip people into doing things, trying to externalize responsibility for things. They'll bring that stuff into the office with you because they bring it everywhere they go. So you will become more aware of times when that's happening. And like Dr. Fogger's saying, if you keep it focused on the patient and on your objective, you'll be less likely to get off course with those things. And talk about these things with your clinical instructors. That's what we're here to do, just to help you get better at this. And part of that's figuring out what your strengths and your weaknesses are. I end just about every session with, what have we not talked about that you wanted to talk about today? And sometimes I get stuff, and most of the time I don't. But there's a lot of value in opening it up, because if there's something they have been putting off for a while, or they were too polite to say, well, I really need to talk about this, it gives them a chance to do that. So, and then it's a good time at the end of the session to say, okay, let me kind of recap what I think I heard you say, and I want you to tell me if I've missed anything. And then I'll kind of give a summary, which is really essentially an assessment paragraph, the assessment paragraphs that we ask you to write in your notes, which is the notes that you turn into us. The assessment paragraph is the most important thing in that document, because I should know everything that's really important just by reading those 4 or 5 sentences. So I'll kind of give that to the patient, and they'll let me know if I'm right or if I'm totally missed something, or if I screwed that whole thing up, which, no, I mean, they're not going to do that. Plus, it lets them know you're paying attention. At the very end of your intake, or with your notes, you'll have a working diagnosis, but then you'll have some things that you're not quite sure if they're relevant or not. Your diagnostic impression is overall what you think is most applicable to this patient at this point. And your plan is, what are you going to do to be helpful? Those intake notes list components to your plan. We won't go into tons of detail here because that's more emphasized in the clinical course. So you'll be working with your clinical instructors and getting lots of feedback on these things. But ICD-10, that's your F code, your diagnostic code. CPT coding is what you did. That's the current procedural terminology. That's the actual procedure you performed. Was it an intake? Was it a follow-up note? Was it if you're working with kids, was it family therapy with patient present? Was there a complexity add-on? That's your procedure coding, which you don't need to know right now what any of that means. Good point, Dr. Fogger. There are inpatient and outpatient codes, totally different. It's the standard way. Every encounter is unique. It's all about insurance. So, in summary, exam 2 is going to be next Monday. We did not have exam 1 due to extremely unfortunate circumstances, so we're going to combine exam 1 and 2 content, which will make it a longer test, which is good. Each question will be worth less. Probably going to be, we haven't really decided, but maybe somewhere between, and again, we haven't decided, so don't quote us on this, somewhere between 40 and 50 questions. As many as 50, which is cool because then each question is just worth 2 points. But standard for us is you will have at least 1 1/4 minutes per question, because that is what ANCC gives you, is 1 minute and 15 seconds per question. So you'll have potentially, a little over an hour to take it. Multiple choice. A study guide is posted in Module 2, which is exactly what you have right here. Unit 2 content, components to the interview. You should know the difference between a HPI and a mental status exam. I'm sure that you will. Oh, I'm sorry. Question. Oh, like select all that apply. Less than 5% of any exam of ours will have multiple answers. Just because ANCC is 100% multiple choice, so we try to model our exams after theirs as much as we can. Screening instruments that discussed. We talked about PHQ. We talked about GAD-7. Don't go bananas in Wheeler's readings because she talks about like the Disorders of Extreme Stress Scale, and those are wonderful. They're not going to be on your test. They are good references to have down the road. But SIGI caps, dig fast, things from mnemonics that you've come across with in these readings or that we've talked about in these lectures. The exam comes from readings and lectures. That's it. Safety. What are indications of suicide risk? Can you identify hypoglycemia? Can you identify would you know that that's orthostatic hypotension, medical comorbidities and labs based on the person's medical diagnosis? What labs would you want to get? What labs would you suspect were abnormal? Just patho coming back. Got to continue with this information. You have to continue with this information because it's going to be on boards. Yes, it's not psychiatrically relevant, but it's relevant to the care of your patients, so got to keep doing it. Fewer than 5% of our tests are ever going to have select all that applies. To answer your question, Tracy, it will be 95% multiple choice. Maybe once in a blue moon, a short answer kind of question, if there's just no other way to get at the information. And here's just Unit 1 content, kind of to remind y'all. Chapters 1 and 4 from Wheeler. Boundaries, self-disclosure, when do you do it, when do you not? Maslow's hierarchy of needs, what's supervision for? Primary, secondary, tertiary prevention, physical assessment coming back around. Any questions? It's 8:02. That's all I got. For any other comments or commercials from you, Dr. Fogger, before we wrap it up?
Not at the moment. I don't have anything to say, except I hope that everybody who's down in Florida and South Carolina and Georgia is back up online and has their electricity back. So yeah, it's just kind of, we're aware of the fact. The test closes at 10 p.m. Central Time, correct? Now, all the times are Central Time. The trick to it is that you want to be in the exam before, in a reasonable period of time before it closes, because I believe at 10 o'clock it'll throw people out if you haven't finished the test by then. So,
Right, right. So that's really why we wanted to say plan on an hour to take it, because it'll shut you down at 10 o'clock Central. So 11, p.m. for our Georgia people, Florida people.
If you have a poor connection in your home, then find a better connection before you take the exam. Find a place to take the test that is as few distractions as possible. Prepare yourself for the exam by doing some deep breathing ahead of time and clear your head. Keep in mind that you have been selected to come into this program, so a little positive thinking can be very helpful as you begin this process. So there are a lot of people who have problems with test anxiety, and I would encourage you to work on yourself. Perhaps take a brisk walk before the exam, just so that you get yourself online and ready to go. And please do eat and have enough in your system so that your brain can function adequately. We want you to do that.
And if you have any questions about any of this content, don't hesitate to email us. We want to help you get this stuff straight. I don't think I've gotten any emails from anybody about any of the content yet, so don't think, oh, they get all this all the time. No, we really don't. So happy to help. Any other questions from anybody?
Looks like it's time to shut her down.
We got her done. Okay, everybody. Y'all have a really good night. Email us questions. Take care of yourselves.
Long time, same bat station. We'll see y'all next week.
We'll do it again. All right, y'all. Have a good night.